public sector mental health crisis, and how serious is it? This is an area, of course, that involves so many people, not only the people with mental health problems, but of course their friends and their families. And we understand that there probably is a very serious crisis. But in order to help us make up our mind about that, we have two really excellent speakers.
I'd like to acknowledge the traditional owners of this land, the Gadigal people of the Aurora Nation, and I also have learnt through the time I had in the Mental Health Commission to acknowledge the individuals who live with mental illness and their families and their struggles to improve their own lives and our services. Now, the title of a crisis in mental health services is a curious one, because to some of us who've lived through a career in mental health services, and you can have a career in psychiatry whether you're a professional or a service user or a family, and we've found that it's easy to get into one of those careers and very difficult to get out of one. But for those of us who've lived through that, it seems to be been multiple crises, and I'm reminded of the literature on the midlife crisis, which was written up first of all by Gail Sheehy, and in a book called Passages, and a few books that were similarly named. And she lit upon the midlife crisis. I've always thought that there's something curious and manufactured and artificial about the midlife crisis, because I think all of life is a crisis, and I think there is something in that. But there is a looming crisis in the disorder and the fragmentation of mental health that we haven't experienced before. Lord William Henry Beveridge, later the first Baron Beveridge, was a complex man, head of the London School of Economics and a social visionary and reformer, but also in some ways an elitist and an eugenics exponent. His 1942 report to the Parliament, the British Parliament, on social insurance and allied services proposed that all people of working age should pay a weekly national insurance contribution. In return, benefits would be paid to people who were sick, unemployed, retired or widowed, and there would be a national health service of some sort, a policy already being worked on in the Ministry of Health and realised through the work of Nye Bevan. Beveridge argued this system would provide a minimum standard of living below which no one should be allowed to fall. It recommended that the government should find ways of fighting the 5 giant evils. They were want, idleness, ignorance, squalor and disease, or in modern parlance, poverty, unemployment, lack of education, poor housing and physical illness. Most of these were then squarely tackled. Most have been improved, albeit sometimes only intermittently. Richard Layard, in his new book called Thrive, says that is where the welfare state has gone wrong. It has assumed that all the key problems of life are external to the mind and spirit. Many are, but certainly not all. There is a 6th enormous 3-headed giant stalking us: mental illness, disorder and distress, which are as old as humanity itself. Even today, this is kept as the invisible giant in the room due to social and political fear and stigma, and is too often left out of our social planning. Yet mental illness is up to 38% of all illnesses in high to medium income countries, and 15% of the burden of disease in most countries. Yet mental health gets less than 1% of the health budget in low income countries, and less than 8% of the health budget in countries like Australia. And Sebastian has told you more up that alley. And that is just the nominal budget, not the actual expenditure, as we will see. So only the 6th giant of unresolved and untreated mental illness has continued to grow inexorably worse. The others have improved, however, intermittently. I recently lectured in several European countries with stark austerity budgets as their governments reacted to the prolonged impacts of the global financial crisis. All I saw and heard was about further withdrawal of resources from their public health services and social services with a deterioration or complete loss of health care and disability cards and benefits at a time of mounting unemployment. These measures were selectively penalising disabled people, the unemployed and students of more modest means, causing ever lengthening queues for urgent mental health assessments and care. I hope that our Australian governments will find another way to bring us gently back to balancing the national accounts, and that they will be able to rethink the imposition of an austerity budget on the most ill, disabled and needy in our communities. Don't get lulled by the last budget, which provided just some people, small businesses, with a soft landing. It's going to be a very hard landing for those people who are on the margins. The most vulnerable of Australian people to everyday life itself and to austerity budgets are those who suffer a quintuple whammy, named after the double whammy or double strength curse described in the 1950s comic Little Abner. Who remembers that? Gee, it's very reassuring that I'm not the only one in the room. And that describes hand-to-mouth existence in a US Appalachian mountain community. The quintuple whammy. Now I know what quintuple is because I've had a quintuple bypass, so I can count to 5. And defined as simultaneous curses or a handful of vulnerabilities and slow burn traumas experienced by individuals with severe mental illnesses. The first is having a psychiatric condition which is severe, persistent or episodic. Either way, this can be a permanent disability, though the person may still not qualify for the disability support pension or national disability insurance scheme as having a permanent disability on proposed criteria. We still have to fight that one off. Number 2, the second whammy, is drug and alcohol dependency, which often co-occurs with a severe psychiatric disorder. Number 3 is physical disability, the ongoing illness, the physical neglect and the reduced life expectancy that Sebastian described. Number 4 is being worn down by dire poverty and other social deprivations like lack of stable and supported housing. And the 5th is being disaffected, marginal or having an alienated existence. Now that's quite something, that triple whammy, that quintuple whammy. The last, the alienated existence, includes Aboriginal people, young people who cannot afford or have dropped out of education and training, unemployed people, homeless or those in unstable housing, disability support pensioners, single parents, abusive trauma victims, elderly people on pensions, transcultural immigrants, asylum seekers, former prisoners in transition to community living, or just being isolated from kin. It would be ironic if it wasn't so tragic that our governments tend to cut essential support services, especially during times of perceived financial crisis, just when people have become the most vulnerable to hopelessness and suicide, often associated with government policies which have denied them educational opportunities, purposeful jobs, general and mental health services and financial support. In both their 2014 and 2015 federal budgets, our federal government has put the states and territories on notice that they will be withdrawing their recurrent investments in health and education by 2017, leaving a huge hole in their recurrent allocations. We know, those of us who've had long experience in the mental health system, that when general health services in New South Wales get put under additional financial pressure, they take even more resources from crucial community mental health services and other community health services than usual. They target especially chronic disability, elderly and palliative care services, and especially mental health services, all designed to provide preventive and ongoing chronic care to keep people living with quality of life in the community without disrupting their lives and without having to have recurrent hospital admissions, all regarded to be at the bottom of the pecking order, so who would notice anyway? So they usually take them for community services where they think services are not salient and the public will not complain. Community health services, and particularly community mental health services, are already being used up as cash cows while they last, and meanwhile they are being dismantled bit by bit. So the looming crisis in New South Wales mental health services. Here's a familiar story. Imagine that you're an ageing lone parent trying to provide home care for a strong 29-year-old son struggling with a smouldering long-term psychosis in an outer local health district of a metropolis in New South Wales. You are lucky if your family gets a home visit from the local community mental health team more than twice a year because it has been run down to half its staffing. Even so, you may only get this input if the person is on a community treatment order, because the team staffing is now so sparse that it can only provide any regular care management for those on involuntary orders. Consequently, this young man goes off his medication and starts pushing his parent around, physically endangering his main carer and precipitating yet another involuntary admission to hospital. This involves an epic cast of police, ambulance, mental health clinicians, causing a stigmatising spectacle in the immediate neighbourhood. There is no protection at local health district level of the mental health budget or the cash subsidy that supports the budget. This is current policy. This has occurred to some extent under successive state governments, but under this administration it has been far more blatant and severe, and the losses to mental health from local health district siphoning have gone from 20 million annually in 2009 by the New South Wales Auditor General's report, to well-informed insider estimates of more than 8 times that now. The biggest impost seems to fall on interdisciplinary community mental health positions, as they are easier and less visible targets than the staffing of the bricks and mortar of inpatient facilities. So the painstaking engagement of early intervention and mobile crisis teams cannot be delivered. The emergency departments and inpatient units get overloaded with urgent psychiatric referrals. Well, you might laugh. It's not funny. If resources were adequately applied and not depleted by local health districts to pay for overruns in medical and surgical procedures, they and their families would not be left alone in the community, with no one to help them but increasingly only the police. Further, the dramatic recent reductions of public child psychiatrist positions and all public psychiatrist positions in rural Western New South Wales and elsewhere are a false economy, especially as there's no undertaking that these savings will be redeployed in mental health at all. There are now few controls on LHD siphoning from mental health budgets. There is no independent or regular forensic level auditing of local health district mental health budgets, cash or service delivery. So there's no real accountability. Reporting on mental health is done with a very broad brush. It could be called the French impressionistic school of organisational accountability. The LHDs are allowed by the Ministry of Health to shift resources allocated to mental health for other purposes, thereby continually eroding and dismantling mental health services bit by bit. Note that not all LHDs do this, but many do, and we can only find a few who try hard not to, but most do. The pre-election enhancement for mental health services announced by Premier Baird in December was most welcome, but it is likely to suffer the same fate of diversion out of mental health. In any case, at only $38 million a year over 3 years, this is only a small gesture compared to the estimated more than 4 times that amount that is taken out of mental health budgets by the local health districts every year. This does not include the savings from mental health intended by the current merging of nearly all dedicated mental health support services like workforce training, mental health service information unit, etc., responsible for the monitoring of quality of services, into generic health services, where again they will inevitably end up at the bottom of the pecking order, losing funding for mental health priorities. These figures are admittedly only well-informed estimates, necessary because so far under this government there have been no systematic audits done or actual expenditures on mental health, actual expenditures on mental health, nor have these details been on the public record. These estimates depend on accounts from very senior and committed public sector mental health personnel who cannot speak up because of continuing instances of severe recriminations. Since we have been making this material, we pulled it together and made it public. Some of those very senior people have been grilled and interrogated, we know. So we know that this is certainly coming to notice in government circles. So the last Internal Audit Bureau report was 5 years ago, and even then demonstrated under a former administration that some LHDs charge their mental health services up to 34% of their budget in corporate on costs, and all indications are that under this administration it's got even worse from there. So where has the 1.56 to 1.62 billions dollars per annum gone that the New South Wales Parliament voted for New South Wales mental health services in the last 2 financial years? 1.62 billion was not the spend, but the then minister before the election kept saying this was the spend on mental health, so what are you worried about? We've increased the spend. Yet in reality, these figures only represented the nominal budget, not the actual expenditure on mental health, nor the financial acquittal, the reconciling of the announced and published budget for mental health services with what actually gets resourced on the ground. In some local health districts in New South Wales, only about 3/4 of this nominal allocated budget went to mental health services. In these local health districts, up to 1/4 of the mental health service budget was taken up of mental health services for excessive and duplicated corporate charges and levies, in contrast to corporate charges being limited to 1/12 of medical and surgical budgets. This is on the figures of New South Wales Auditor General 2013. These allocations appear to be illusory, with apparent intent to provide a faithful imitation of life, of what they are not, like an old Wild West movie town frontage. For mental health, they are merely just a theoretical or even fictional starting point. What will be the consequences if this is allowed to continue? The New South Wales Government has endorsed the strategic plan of the Mental Health Commission of New South Wales, which proposes shifting the balance of mental health services towards the community, in accordance with both the evidence and the wishes of service users and their families. But as we have learned from successful shifts elsewhere to community re-provision, major new investment in community mental health services must precede any decrease in hospital placements to move people with mental illnesses from institutional to stable, supported community living, such as the instances that Sebastian raised. However, successive New South Wales governments, more than any other Australian jurisdiction, have continued to squeeze and deplete community mental health services. History has also demonstrated, and inevitably, if not effectively restrained, such serial disinvestment will lead to further gaps in and dismantling of mental health services, worsening outcomes for people with severe mental illness, and at some point, a formal calling to account by disaster, the media and public inquiry, as both unavoidable deaths and other critical incidents accumulate. So what steps can government take to start correcting this looming crisis? We need a process for annual independent full-scale forensic audits of mental health budget, cashings and service delivery needs, service gaps and quality improvement. All of those need to be audited, to be instituted with annual reports to Parliament. This is the only way to get to the truth and ensure some stability of mental health resources. The best way is to strengthen the Mental Health Commission of New South Wales by providing it with the statutory and delegated powers of audit over mental health budgets, expenditure, acquittal and quality of local health district and statewide mental health services, reporting these comparatively on an annual basis. Number 2, government must instruct the Ministry of Health and the local health districts to restore to mental health services the mental health resources taken from mental health budgets over the last 4 years. The budgets of statewide mental health services and mental health dedicated support services should be restored to a circumscribed mental health entity, like the specific Children's Health local health district equivalent called New South Wales Children's Hospital Network. It's complemented by New South Wales Kids and Families, which is their auditing and monitoring network, which is run by a former Minister, Ron Phillips. But it's run at a very senior level and does auditing of what is spent for New South Wales kids. So if they can do that for something so substantial, where mental health services as a whole is much more substantial and requires a similar type of strategy. Thirdly, we need to follow the evidence to make a real difference, to disseminate throughout the state with proxies in rural and remote areas the evidence-based community mental health interventions and teams which will achieve the most practical and quality of life improvements in personal outcomes. We need to walk together with government on a buy or try partisan basis wherever possible by providing government with reliable and robust arm's length and even sometimes painful advice about whether the reforms are adequately resourced and on track or not, and by sustaining good communication between them, service users and providers. The Mental Health Commission of New South Wales should be strengthened to enable this on a continuing basis. And lastly, we need a firm commitment from the Premier, as good mental health services are truly an all-of-government endeavour, and all sides, that the leaking of budgets will stop and that adequate enhancements will be made to shift the balance of mental health services more towards the community, implementing the strongly evidence-based modules of community mental health care widely, while also funding inpatient units properly as essential elements, though no longer the centre of gravity of the spectrum of services. If resources had been adequately applied and not depleted by his local health district to pay for the overruns in medical and surgical procedures and the imposed costs of otherwise worthy emergency department targets, the young man and his family in our story should have had the regular services of an assertive community treatment team which could home visit on a daily basis if required to keep him engaged in treatment, to keep him and his family out of danger, to ensure that his life was not disrupted by repeated hospital admissions, to access, if needed, a voluntary community-based respite household facility such as the one or two in New Zealand and in Victoria that was named by Sebastian, and where he could also receive a wellness and a resilience program on a 7-day-a-night basis, and to relieve his ageing family of carrying the burden of his home care virtually alone. So far, all my concerns have been pitched at a macro level. And let's go directly, in closing, to the micro world of our clinical practice, and I offer you some tips that I've learnt on the way. Embrace complexity. It is not a complication or obstacle to our work, it is the very core, the guts of our work. We should celebrate this approach, and we should role model and convey this to other medical health and welfare colleagues. Go wider, widen the context of our scope of inquiry and for our range of our interventions. Not just taking a biophysical or even just a biopsychosocial approach, as Engels famously exhorted us, but a biopsycho, socio-cultural, environmental, ecological, the world, the universe and everything type approach. So a wider framework, including the spiritual. These complexity factors may involve co-occurring drug and alcohol, physical and cognitive disorders, or ongoing disabilities, and or social determinants of mental illness such as unstable housing, no job and living in poverty. I'm talking about addressing environmental factors as the only psychiatrist who's been working regularly in Wilcannia for well over 30 years with the team and the Royal Flying Doctor Service. I have often felt like a recurrent clinical band-aid over fragmented services. The Aboriginal community there, in the face of a 10-year drought, told us, if the land is sick, we are sick. I used to have fantasies on the way that just maybe we need to put Prozac in the water supply there. Then the drought broke and the land blossomed, new vast lakes emerged, and the river and the fish started running. I realised then that all you have to do is to make this community much happier. All you have to do to make this community much happier is to put water in the water supply. And talking about addressing cultural factors, most traditional cultures have two basic cultural tools to get us through life crises: rites of passage and the extended kinship network. In our modern societies, either or both these tools may be suboptimal or missing. In these circumstances, finding an ongoing care coordinator, counsellor or mentor may provide you with the guidance and support to get from one stage of life to the next. And if your extended kinship and caring network is deficient, you might find that a proxy arrangement can be provided for a while by a really close confidant, a mental health team, a self-help group, or a multiple family group, or a peer worker who can be your spirit guide, like a wounded healer, until you can rebuild your own life. We've learnt to shift as much as possible from a therapeutic to an educational and training framework, especially if this can provide new and sustaining skills, enduring qualifications and empowerment to help others as a peer mental health worker. This entails co-production of solutions in partnership between clinicians and individuals and families with a local base from life experience. The advent of recovery colleges where you can start by working on your own recovery, and one day you might find that you've earned a degree that will get you a better job. And so recovery colleges, we hope, will blossom. Whether as service providers, service users or caring and supporting families, let us also celebrate our sustaining relationships, our intimates, our confidants, our immediate and extended kinship systems, our mentors and our mentees, our peers, our service users and our families and their families who give us such precious feedback and encouragement to improve our services, if only we will listen. Whatever is the favoured technology or therapeutic intervention or therapy of the moment, our key tool is the relationship, a continuously engaging therapeutic alliance throughout the encounter, however long it lasts,